Well, thank you for inviting me to talk to you guys today. And as you said, I work in the allergy field. And what I'm going to do today is start off with some basic pathophysiology. And hopefully that's not going to confuse and or bore you guys too much, because what I'm going to do is to try and show how important this basic pathophysiology is in terms of the clinical implications that it has for your diagnosis and management of this extremely common condition of allergic rhinitis. So first of all, we're talking about an allergic condition, which is one of the many different ways that the immune response can be aberrant. If it's inadequate, you can have an inborn error of immunity or an acquired immune deficiency. If it is directed against harmless environmental antigens, that's when we get allergic reactions. You can have direction of the immune system against self-antigens leading to autoimmunity. But obviously what we'd really like it to do is to kick the coronavirus, fight off pathogens, and lead us to have good protection against infections. The process of allergy in really very basic terms is where a foreign substance, usually a pollen, such as house dust mites or mold or grass or tree pollens, enters the body, sensitizes you, causes a class switch to IgE antibodies, which then are bound to your mast cells and your basophils, and then enter the body again, causing release of the histamine and other chemicals and resulting in an allergic reaction. But this understanding of the immune system doesn't really allow us to draw those clinical important messages that I want to stress today. So I'm going to go into a little bit more detail about some of those stages. The first stage of any immune response is the ingestion of an antigen, whether it's a bacteria or a pollen, by an antigen-presenting cell, cutting it up into tiny little pieces and then presenting those specific epitopes onto the surface of that antigen-presenting cell, and then presenting it to a T cell. This presenting to the T cell needs to be done under very controlled circumstances to make sure that there isn't any problem with autoimmunity. And that's done by making sure that your CD80 and your CD86 on your antigen presenting cell are connecting to your CD28 on your T cell. And this is a mechanism that we can use in our regulatory immune system in order to prevent autoimmunity. And I'll show you a little bit about why that's important in a short while. At this stage, what happens is that naive helper cell, that Th0 cell, decides that it's time for it to go to school. It's deciding what it's going to do when it grows up. So it gives itself a message and every other cell around it a message that, okay, I'm ready to be taught. And the way that it does that is it releases a cytokine interleukin-2, which really causes proliferation of more of those naive helper cells and secretes a tiny little amount of interleukin-4 and a tiny little bit of interferon gamma. And those two cytokines are the signature cytokines that are involved in type 2 immunity and type 1 immunity, respectively. So how does this Th0 cell decide what it's going to study at university? Because it's got a lot of different decisions that it can make. Not only is it surrounded by other antigen-presenting cells that themselves are secreting a whole bunch of different interleukins and cytokines, it's also changed, that soup, that environment around it, is changed by your genes. And if you're a person who's got lots of different allergy-related genes, then you'll find that you are skewed towards one of those particular phenotypes, which is the type 2 immunity, which, as I've said, is one of those many different pathways that that Th cell can take when it goes to university. It can either grow up to be a Th1 cell, which is supposed to clear intracellular pathogens, or a Th2 cell that is supposed to clear parasites, or a number of different other pathways that cause both good things as well as bad things if they're dysregulated. But I'd like to draw your attention to the guy at the bottom, these regulatory T cells. These regulatory T cells actually interact with all immune cells to control the inflammatory responses. And I'm going to spend a little bit of time talking about the importance of regulatory T cells in deciding about how you are going to go on and the clinical relevance of those regulatory T cells. So let's forget about Th17 and Th22 cells for the time being and focus just on regulatory immunity. They're seen on the left-hand side, your Th1 immunity in the middle, and your Th2 immunity on the right-hand side. Because as I've said, that local soup of cytokines, that decides and tells the cell what it's going to be, what it's going to study when it goes through university, and what hopefully it's going to be when it grows up. And those T cells in turn, at the end, will secrete cytokines, which are the effector cytokines, which actually do the job of instructing the immune system in those different pathways. One of the things I want to show you straight away is that once you've decided to go into one form of immunity, you're kind of almost stuck in that pathway, because the effector cytokine of regulatory immunity, TGF-beta, is the same cytokine that causes you to have regulatory T cells in the first place. Interferon gamma is both the causal cytokine for Th1 immunity, but also one of the effector cytokines, and the same with IL-4 for type 2 immunity. So once you've skewed your immune system in one particular direction, you find that it's pretty difficult to make it change its mind. You can't go back to university and study to be something else. So I'm going to speak a little bit about the different types of immunity, and the most important of those types of immunity is the regulatory system. This regulatory system basically damps down directly all of the other branches of immunity and has direct effects where it kills T cells, and it also binds to that CD80 and CD86 molecules, which then prevent the second signal of antigen presentation and therefore stop additional cells from being recruited into further immune responses. And this is a very, very important part of the immune system that we forget about quite often. In particular, we often tend to think about type 1 immunity and type 2 immunity as being the main players on the stage, and that they're in a balance between each other. If one goes up, the other one goes down, and that they can't really both be operational at the same time. And this is true to a certain extent, because Th1 immunity on the top and Th2 immunity on the bottom have those positive feedback loops where they speak to each other and reinforce their own type of immunity, but they also have these negative feedback loops. You can see that type 1 immunity with interferon gamma damps down type 2 immunity, and type 2 immunity with interleukin 10 damps down type 1 immunity. So they are in a bit of a seesaw between each other. And what we want to do is we want to focus a little bit on what that means for us in the world of allergy. So before that, let's just quickly jump to type 2 immunity and what it's going to do at the end of the day. At the end of the day, that type 2 immunity is going to convert your B cells from IgG producing B cells into IgE producing B cells. So that's a class switch. And that moves you away from a protective immunity into an aberrant allergy type immunity that then can cross-link and cause effector mechanisms to go into effect. And it also causes this memory response with T and B cell memories. And we seem always to think, well, once we've started this process, we're going to go on and continue this process, and we're going to get type 2 immunity. It's going to always get stuck there, and we're never going to have type 1 immunity, and we are doomed to have allergy forever. And what we forget is that the regulatory T cells are far more important than any of these other branches of immunity. So if your regulatory T cells are in balance, you're going to suppress both type 1 and type 2 immunity. And only if your regulatory system is damaged in that some way are you going to be able to manifest at all with some aberrant form of a reaction. So why is this important? Why am I yapping on about interleukins and regulatory T cells? I'm yapping on about it because we make mistakes. We make big mistakes in thinking that allergen exposure automatically leads to sensitization and then leads onto allergy. And that's not true, because allergen exposure can lead to sensitization. It can lead to the formation of those IgE antibodies with the detection of those IgE antibodies either by skin prick testing or by allergy blood testing. But in some cases, and in fact, the majority of the cases, the sensitization is suppressed by that normal regulatory mechanisms of your regulatory system, and the person is tolerant to that allergen. So these people have what are often referred to inaccurately as positive allergy tests, but they're not allergic. So sensitization may be useful in suggesting allergy or excluding an IgE-mediated process, but is not definitive proof of having allergy. We must always interpret those skin prick tests or Immunocap tests very, very carefully because of this fundamental principle that sensitization can be regulated and is not synonymous with allergy. Only in some people who have lost their normal tolerance, whose regulatory systems are not working, they then go on to enter the next phase of the reaction, and that's the elicitation phase of the reaction. When the elicitation phase takes place, we cross-link 2 or more IgE antibodies, and that causes the release of pro-inflammatory mediators and the triggering of these reactions in mast cells and basophils that comprises 3 very important and distinct phases, each of which can be targeted with different types of drugs. So for example, we have the immediate release of granules, and most important product of those granules is histamine. These cause immediate onset of some of the more irritating symptoms of allergies, such as sneezy, itchy, running, and hives. Over minutes, you have production of newly formed mediators from the cell membrane of those cells. The most important of those is the leukotrienes, and those cause, in the setting of asthma, wheezing, and bronchoconstriction, and in the setting of rhinitis, some of the mild blockage and a little bit of the postnasal drip. But the late phase of the reaction, which takes place over hours, is the production of those effector cytokines, which cause eosinophilic inflammation in those tissues, with swelling, thickness in those tissues, blockage of either the nose or the lungs, and activation of eosinophils, and further recruitment of B cells into plasma cells, and further production of allergen-specific IgE. The reason this is important, I'll come to when I talk about the therapy of allergic rhinitis, is about the way you educate your patients and the specific medications that you need to use in order to address all 3 different phases of that effector mechanism. So what we've been talking about so far is everything on the left-hand side of this diagram. You can see at the top there, you've got your allergen that is in the epithelium with an antigen IgE interaction, causing the release of those mediators from your activated cells, and then some of your symptoms. But also on the right-hand side, we've got branches of the innate immune system, and that involves irritants and various microbial products that can directly interact with the mucosa, cause release of different mediators like TSLP, IL-25, IL-33, and IL-17, which then cause a reaction in your innate lymphoid cells that have the same kind of mediators later of IL-4, 5, and 13, but they don't come through an allergy mechanism, and they can be interacted with not through the process of allergen immunotherapy, but they can be modulated by our microbiome. And this mechanism is probably responsible for the allergy epidemic that is associated with modern living from industrialized countries, where pollutants and irritants are causing type 2 skewing of our immune system. So let's now go into some of the clinical implications for practice. So first amongst those is that we have to remember that there are different types of reactions. When we talk about rhinitis, we're not always talking about allergic rhinitis. There's infectious rhinitis and there's non-infectious rhinitis. The non-infectious rhinitis is divided into allergic rhinitis and non-allergic rhinitis. And clearly, only the methods of diagnosis, management, and therapy can be applied for people with allergic rhinitis. How do you know that it's allergic rhinitis? Well, you know that it's allergic rhinitis because of clinical signs and symptoms. Your diagnosis of rhinitis with your itchy, runny nose, your sneezing, your postnasal drip, the clinical signs that you see of allergic shyness, of Denny Morgan folds, of a long face, a high arched palate, and looking in the nose to see those pale turbinates. But we also often want to know, is there evidence on a laboratory basis of inflammation or of sensitization to allergens? And this is where we are running into a little bit of danger. Many people think that if you have an allergic rhinitis, you need to do skin prick tests or serum IgE, either total IgE or specific IgE, to make sure that your patient is allergic. And that's not true. And it's not true for a number of different reasons. First of all, total IgE is not specific for allergies. It is usually raised when there's parasite infestation, and it is raised in rare conditions such as hyper IgE syndrome and in allergic bronchopulmonary aspergillosis. But it is neither sensitive nor specific enough to be a sign of allergy. So that's the first really important message. Don't do total IgE tests at all for patients with allergic rhinitis. The second thing is that people think that if you have negative specific IgEs, you don't have allergic rhinitis. Well, that's also false, because you can't test for every single possible allergen, and therefore you might be allergic to something that you haven't tested for. You haven't tested for that allergen, and you're going to say, well, that person doesn't have allergic rhinitis. That's another mistake. So the absence of sensitization doesn't mean that you don't have allergic rhinitis. And in fact, even more importantly, there can be some patients who've got typical allergic rhinitis with all those clinical signs who have what we call local allergic rhinitis. They may well be allergic to house dust mite, the most common allergen, and that allergen might cause, when you put it into the nose, symptoms, and you could find that specific IgE in those nasal secretions, which is done as a research tool that isn't done in clinical practice. But the inflammation is limited to the nose. It hasn't spilled over into the blood, so your skin prick tests and your Immunocap tests in the blood will be negative to house dust mite, even though you're actually allergic to house dust mite. And then finally, the other important point that I've already stressed is that you can be sensitized, but have your regulatory T cells in order, so they're suppressing that sensitization. So you've got a positive allergy test, but you're not sensitized. So this is an important point, is you do not use a specific or a total IgE test in order to make a diagnosis of allergic rhinitis. You might use it later to help you decide how to manage the allergic rhinitis in some patients, but you don't need it to make the diagnosis. It doesn't help you. It's going to lead you astray. So then, apart from the clinical signs and symptoms that I've told you about, how then do you define that a little bit better to work out, is this individual patient got allergic rhinitis or something else? And there are a couple of really nice, easy clinical tips. The definition of allergic rhinitis is 2 or more of the symptoms, the typical symptoms of a runny nose, sneezy, nasal obstruction that is bilateral, itchiness, and the strong associated with allergic conjunctivitis that occurs either intermittently in the form of intermittent allergic rhinitis, or for a long period of time in the form of persistent allergic rhinitis, which we used to refer to as perennial allergic rhinitis. And there are a couple of these clinical features that I want you to look out for that say that you think this actually is not allergic rhinitis. If there's symptoms on only one side of the nose, if there's nasal obstruction without any of the clinical signs, if the runny nose is very green and snotty, or if there's bloody secretions, that's often not allergic rhinitis. If there's a lot of posterior nasal discharge without anterior nasal discharge and the other signs, if there's pain, and if there's abnormalities in your sense of smell. All of these are warning signs that you're not dealing with allergic rhinitis, that you have another one of these conditions. So I want to go on to now to discuss, if I've said that you're not going to test for allergen sensitization to diagnose allergic rhinitis, when are you going to test for allergen sensitization? So here there are two important principles. Don't test for allergy testing for a specific allergy as a cause of allergic rhinitis when it's not going to make a difference to your diagnosis and your management in the person. In other words, when the allergic rhinitis is mild and can be dealt with adequately by pharmacotherapy, or whether you've got a person who is in a situation where avoidance or immunotherapy is going to be impossible. So if somebody has got limited resources at their disposal and you're not going to tell them that they must make major changes to the way their house is set up and run and, buy expensive vacuum cleaners and get rid of all of their soft furnishings, then you're not going to test that person for allergen sensitization. But on the counterpart, when must you test your patients for allergen sensitization? Well, if your allergic rhinitis is moderate to severe and it's not responding to your pharmacological management, then you must think of recommending a specific avoidance measure. And you're not going to just tell every single person with allergic rhinitis, well, avoid house dust mites or avoid pollen or avoid grass, because those specific triggers are specific for each single person. They are different. So you cannot recommend blanket avoidance for people with allergic rhinitis, put them through the expense and the hassle that's involved with that, and think that it's going to have any therapeutic benefit for your patient at all. You must test them and then individualize an avoidance plan for those specific allergens. This, by the way, is different from irritants, because if you have allergic rhinitis, every single patient who is exposed to strong smells, cigarette smoke, and other chemicals will have an irritant type of reaction because they've got hyperactive mucosa, and you should be recommending blanket avoidance of cigarette smoking and other exposure to irritants to all your patients with moderate to severe allergic rhinitis. Once you've decided that you're going to do an allergy test, you've got the choice between doing skin prick testing and Immunocap testing, and both of them have their pros and cons. Your pros of doing your skin prick testing is that the result is available immediately. The patient can see the reaction, but the problem with it is that it does require people to have skill and expertise in doing that test, and that it can't be done if the person has been on antihistamines or if they've got severe eczema, which is a common concomitant disease with allergic rhinitis. The advantages of doing an Immunocap blood test is that you can do it to any allergen that you want, really. You have one blood draw and it's unaffected by any of the medications that the person is on. So it's a very convenient thing to be able to do. What's important about both of these tests, no matter what you do, whether you do an Immunocap or a skin prick test, is that you consider it as being a progressive test where the higher the reaction it is, the more likely you are to be clinically allergic to that particular thing, in this case, an aeroallergen. It's not a yes-no answer. There is no such thing as a positive allergy test and a negative allergy test. They need to be interpreted in lines of the history that the person has. So in order to measure your allergy skin prick testing, you need to measure it at the largest point and at a 90-degree diameter from that. Add those two together, divide them by 2, and then get your mean wheel diameter. And if you're doing skin prick tests, you also need to subtract your negative control from that to get an accurate result in case the person has a very sensitive skin. The allergy testing that you can do with blood testing is easier and quicker, and you can do those mixed screens such as a phareotop, which is a variety of different inhaled allergens all at the same time. You can do single allergens, for example, house dust mites, and you can do specific components of those allergens as well. But importantly, select your test depending on the history and the patient's environment. If the patient lives at the coast, you're going to be thinking about house dust mites as being the most important allergens and certain grasses and trees that live in that area. If they live in the countryside, they might be exposed to molds that live in thatched houses, or in forests, they might be exposed to different kinds of trees. And on the highland, and interior parts of our country, they're different grass and tree pollens from those that you find at the coast. And just to stress yet again, do not measure total IgE at all. It doesn't help you at all in your diagnosis or management of this condition. The other thing I want to talk about with regards to this pathophysiology is those different phases of the reaction I showed you. Remember, I showed you the immediate release of the histamine, the longer term release of the leukotrienes, and then your very late phase reaction, which is your allergic inflammation. And clearly, each of those can be addressed by different types of medications. So, for example, the antihistamines work on your immediate phase, and because of that, they're very good for the itching and the running, and a little bit for this and for the sneezing. The decongestants will work for your nasal obstruction, but do nothing on any of those other pathways. They only work on your end organs. Your chromoglycate, which is a mast cell stabilizer, will work a little bit. Your leukotriene receptor antagonists will work a little bit on each of those, but really it's your intranasal corticosteroids that will work on your long-term symptoms, which is the nasal obstruction, and then over a long course of time will lead to damping down of the rest of those reactions, and therefore eventually reduce the different types of symptoms that you get from the acute phase as well. So one of the key messages that we have for our patients is that inflammation needs to be dealt with all allergies. With all allergies, we talk about reliever therapies, which either deal with that acute phase reaction or the end organ symptoms, and we talk about controller therapies. And the controller therapies need to be used as a regular controller therapy every single day, whether the patient is symptomatic or not as demand therapy. This importance of the use of controller therapy regularly is also why in allergies we have a central role of education, recognition of symptoms, the use of controller treatment, and the technique by which people use their treatments. Because every one of our allergic conditions requires us to co-opt our patients to use those medications that are based at inflammation, even though they don't feel immediate benefit. So we have to do a lot of training. This is the most recent guidelines for the management of allergic rhinitis. You can see on the left-hand side in green, there's mild intermittent allergic rhinitis, where you do that basic education. You avoid all of your irritants, and you can use an oral or a local non-sedating antihistamine. And if that doesn't work, or if you prefer, and if you have concomitant diseases that could be treated with a leukotriene receptor antagonist, such as asthma, you could use that as an alternative therapy. In the blue stripe, you have moderate to severe or persistent symptoms. You're going to continue with your education, your irritant avoidance, but at this stage, you might be thinking about doing your skin prick tests and allergen avoidance because it's severe enough. And that you need to have an intranasal corticosteroid. Other alternatives are oral or local non-sedating antihistamines and leukotriene receptor antagonists. If your disease is not controlled at step 3 therapy, the latest ARIA guidelines recommend intranasal combination therapy, which has only just become available in South Africa. And there are other combinations of therapies that can be used of both a controller and a reliever at the same time. The combination therapy comprises an inhaled corticosteroid and a local antihistamine in the same device, or you could use an intranasal corticosteroid along with oral or local non-sedating antihistamines. The advantage of using it in the single device is that it's a little bit easier for the patient, and you have this almost enforced adherence where every time they take a reliever dose of their therapy, they also take a controller at the same time. For severe and uncontrolled allergic rhinitis, you're going to continue with the same treatments. You're going to consider immunotherapy, look at whether there are alternative diagnoses, and in the very severe cases, you're considering immune modification therapy with omalizumab, a biologic, or surgical treatment. I'd like to look at the very bottom part of this algorithm, which is the issue of rescue treatment. For mild, intermittent, moderate to severe, or persistent symptoms, you are going to use rescue therapy with decongestants for about 7 days with either oxymetazoline, xylymetazoline, or one of those other topical vasoconstrictors, but remembering not to use them for more than 7 to 10 days because of the risk of rhinitis medicamentosa. You could use normal saline in the form of sprays or of washouts. You're going to increase your local steroids using formulations that are just a bigger volume and or higher concentration. And you could occasionally add nasal anticholinergics. For the very severe people who are having a massive allergy attack, you could use a short dose of oral corticosteroids. But I do want to stress that intramuscular and systemic forms of corticosteroids are not in any treatment algorithm for allergic rhinitis, even though they work exceptionally well, because the risk-benefit ratios are not favorable and they do cause long-term side effects from depot injections of steroids, including very nasty things like cataracts and buffalo hump and diabetes and skin thinning and all sorts of other problems. So really do make sure that you get a decent intranasal corticosteroid in, that you've trained your patient how to use it properly by blowing the nose beforehand, using it by directing it sideways, laterally, away from the septum, breathing in gently, but not sniffing and snorting it and then swallowing it down into the back of your throat, and avoiding blowing your nose afterwards of using your intranasal corticosteroids. And then if it's very severe, to consider using those decongestants, washouts, and increased local steroids, which in really the vast majority of patients with allergic rhinitis is more than enough to get it under control. One final thing that we talk about with allergic rhinitis is the possibility of doing allergen immunotherapy. And I'm not going to go through any of these pathways by which we change the immune system to push it back into the regulatory system, but remembering that the regulatory system can suppress immunity at the beginning, and we can trick the immune system with allergen immunotherapy into becoming resistant to allergens that you previously were susceptible to. And this is the only actual curative therapy for allergic rhinitis. The guidelines are really that this is a final end of the pathway. You're going to make sure that your diagnosis is correct, that you've confirmed sensitization to relevant allergens, because you need this to determine which allergen you're going to use for allergen immunotherapy. That the person has been treated in the ways that I've described with appropriate pharmacotherapy, that they're avoiding their allergen where possible, that they've got ongoing symptoms with poor control despite good adherence, and only at that stage are you going to consider using allergen immunotherapy. And this is really some of these risk-benefit ratios, the age, making sure that there's no contraindications, that the patients are completely on board, and that they're going to be able to adhere to a therapy that actually requires 3 years of therapy, either subcutaneous or sublingual, in order to have that permanent therapeutic benefit. But why am I going on about this if it's, takes such a long time and if you have to have so many other things? Well, the reason is because allergic rhinitis can actually be a severe disease, and it can have severe impacts on patients' quality of life. And the evidence for both subcutaneous and sublingual immunotherapy is evidence level A. It's as good as the other pharmacological interventions that we have, and in fact, much better than allergen avoidance. And there are a large number of studies showing better symptom scores, less medication use, and better quality of life with patients with both subcutaneous or sublingual immunotherapy. In the United States, people mix allergens together. We don't really do this because there is problems with mixing allergens together and problems in standardization. But we can use different groups of allergens together when they have cross-reactivity. So for example, you could just desensitize somebody against one house dust mite rather than having to mix them together and do all the different house dust mites. So it's also potentially unnecessary to mix different allergens together. This modality of therapy is safe when correctly applied. There are some systemic side effects from subcutaneous immunotherapy, and there's skin redness, itching, and swelling. And for sublingual immunotherapy, there are topical reactions that are in the mouth. There are some absolute contraindications with patients who've got asthma, people who've got autoimmune diseases or malignancy, and some relative contraindications, probably the most important of which isn't there. Oh, it is there, is that where poor adherence is very unlikely. These are the medications that are available for immunotherapy in South Africa. You can get sublingual immunotherapy or subcutaneous. These are the allergens vaccines that we have. And then the oral tech sublingual spray that can be given for patients every single day and can reduce their symptoms in the long term. Both of these forms of therapy are disease modifying. They have equal effect on symptoms and medication, but sublingual immunotherapy can be done at home, whereas subcutaneous cannot. On the other hand, sublingual immunotherapy is much safer and is easier for adherence. And there are some even more rare and technical future approaches for immunotherapy that are in process of being investigated in various different settings. So in summary, what I'd like to leave you with as key messages is that understanding pathophysiology of allergic diseases has important clinical implications. Most notably amongst those is that sensitization is not the same as allergy. You need to interpret your allergy tests very carefully, even for error allergens. They don't help you for your diagnosis of allergic rhinitis and can only really help you for deciding which allergen that person should be avoiding, and therefore should only be used in people who you are thinking of allergen avoidance. The treatment of allergy requires you to pay attention to all three different effector mechanisms, both symptomatic treatment, which can be used as required, and anti-inflammatory treatment, which has to be used every single day, whether your person has allergic symptoms or not, as a regular controller therapy. And there's very strong evidence for the use of allergen immunotherapy in allergic rhinoconjunctivitis in order to skew your immune system back to where it originally came from and make sure that your disease is actually cured. So I'd like to thank you and check if there's time and interested in asking any questions. And also remind you that all of the material that I've presented today and lots of patient educational pamphlets and brochures about how to treat all of these different allergic conditions are available on our Allergy Foundation of South Africa website, www.allergyfoundation.co.za, and that if you want to join us at any of our masterclasses, the next one and the final one for 2022 is coming up on the 29th of October on skin allergy, which is eczema and urticaria, and also an approach to drug allergies on the 29th of October. And you could email us at training@allergyfoundation.co.za. So with that, I'm going to see if there's the opportunity to take questions from anyone. I don't know if you'd like to do them via hands and people speaking or on the chat.
No, I've already summarized some of them. Colleagues, if you want to really make a comment live, feel free to raise your hand. Prof, thank you very much. This was quite insightful and really empowering. Maybe before we start with our questions, just to remind colleagues that today's webinar is sponsored by Bayer. And at the end, they would like to have your 5 minutes just to share with you more information about some of their products. Prof, yeah, you know, quite an empowering session. We have, obviously, our audience is a bit mixed. So I want to start maybe with a lighter note to say, for a primary care practitioner, you know, how do they approach a patient who presents with a suspected rhinitis? What would be the key things they should be focusing on? Though I think it was covered in your talk, maybe you can just focus on key things.
So I think remember that your history and your physical examination is going to make the diagnosis. So recurrent itchy, runny, sneezy, those are the symptoms that you look out for. Then you look for in the nose to see that there's pale mucosa in the nose, shyness around the eyes, folds under the eyes. Those are the important clinical signs, and then often this conjunctivitis as well. And then remember those signs that I told you means that you need to think of anything else. If there's bleeding, if there's lots of pus coming out of the nose, if it's only on one side, if there's pain, or if there is lack of smell. Those are the things that means this is not allergic rhinitis. So that's one of the important things.
Thanks. Thank you, Prof. Let's see if we can take a hand from MD Moshood. Doc, you may make your comment. Yes, we are. Dr. Haruna, are you able to hear me? Oh, okay. I think I'm not sure. Dr. Haruna, let me give you one more chance. Your mic is unmute.
So while we're waiting for that, Doc, I'll answer some of these questions I can see in the question panel.
Okay. Yes.
First of all, for an Immunocap, you do not have to send a chemistry tube on ice. It is a chemistry tube, it's clotted blood, but antibodies are incredibly stable, so you don't have to transfer it to the laboratory in any specific way. You can just send that tube as it is, but remember, don't do the total IgE, only do the specific IgEs. Anyone can request testing for allergens, but it depends in the public health service whether your individual hospital is going to let you do it or not. So I would encourage you to discuss this with your specific hospital if you're in the public health service, and check to see which of the specialists are able to order tests for allergen sensitizations. More important than that, Muazzam, is making sure that in your pharmacies, the medications that we need to treat allergic rhinitis are routinely and regularly available. Because we do find that particularly in primary care, there's scanty availability of even the most basic problems like asthma pumps, spacers, intranasal corticosteroids. So really just doing some advocacy on behalf of our patients to make sure that these medications are available is important. I've noticed that anonymous attendee brought up the idea of allergics. So I don't like using trade names, but I do want to make the point that first generation antihistamines can be used for allergies, and they're very good at antihistamines, but they are associated with side effects. The side effects that you get from first generation antihistamines include drowsiness, and then in children, learning disability, and actually poor quality of sleep during that night, leading to tiredness the next day. So for the chronic use of medication, we really do prefer a second generation antihistamine, and any of those are good. They include cetirizine, levocetirizine, fexofenadine, loratadine, desloratadine, and all of the other second generation antihistamines. And then Richard asked this really important question about what is the minimum duration that you want to give the intranasal corticosteroids and the antihistamine. Richard, for the persistent allergic rhinitis, you can and should be using those intranasal corticosteroids long-term. There are no long-term side effects from using intranasal corticosteroids. They don't cause raised intraocular pressure. They don't cause thinning of the mucosa in the nose. They don't cause you to have, hypopituitary axis problems. So they can be given safely long-term, provided that you are directing them away from the septum towards the side, because it is pointing them towards the midline that causes you to have that nasal bleeding.
Superb. Prof, maybe this one coming from me, with regards to immunotherapy, is there something that is available in the country, either for research or or in the clinical setting? I'm not sure. In the Cape Town, Western Cape, how are things there?
It's available, but unfortunately it needs to be applied for through Section 21, because none of the immunotherapy formulations are registered with the HPC, with a Medicines Control Council. The reason for that is not because they're not good, it's because every single allergen is a different drug. And for them to register it would have costed millions and millions and millions in order for them to do it. So it's not that easily available because it needs to go through Section 21 application process.
Superb. Let's see if Lindiwe is able to unmute. Lindiwe, you may ask your question live. I hope it's a real hand that is up. Lindiwe.
Lindiwe, Utini.
Prof. Okay, Prof. I think Lindiwe is still thinking about this. What I would like to ask, Prof, maybe can you share with us around patient education, some of your initiatives and what resources are available, particularly for allergy and rhinitis?
Sure.
Yeah.
So again, please do go and see all of this on the Allergy Foundation website. That's www.allergyfoundation.co.za, because there are a huge amount of patient brochures that are available there. Julia Otokile asked a specific question about a diet that one can or should follow when suffering from allergic rhinitis. And the answer, Julia, is no. There's no diet, there's no food allergens that are triggering allergic type rhinitis. Even for eczema, where people believe that eczema is triggered by food because of the strong overlap between people with immediate type food allergy, that's urticaria, angioedema, hives, etc., in the setting of eczema, there is no specific diet that should be put on for all people with eczema, no diet for people with allergic rhinitis, no specific dietary modifications for people with asthma. And in fact, modifying people's diets in this way can be quite bad for them because it can lead to, in some cases, I see patients with malnutrition who've received poor advice to go on specific types of allergic rhinitis.
Hey,
there are a couple of
that's
extra
powerful.
questions here that I can see. Can allergic rhinitis lead to snoring? Yes, Abel, I forgot to mention that. Absolutely, it can lead to snoring. And that's one of the clinical signs that you should look out for. And then Uzezi Ugbogidi asks about saline drops. Do they have a role to play in management of rhinitis? And the answer is definitely yes. Both saline drops in the form of sprays or drops or washouts are very effective in allergic rhinitis because they wash away the allergen, they wash away all those chemical mediators and interleukins and cytokines and histamines that I've been talking about. And most importantly, they wash away the snot so that you can use your washout, get rid of the snot, blow your nose, and then when you use your nasal spray with your steroid is going directly onto the mucosa and can have a good effect instead of getting trapped in that ball of snot. And that's one of the key messages that we give our patients for patient education and training for allergic rhinitis.
Yay, powerful, Prof. Prof, now these combination therapies, we had one talk on adult asthma, and we saw that in the public sector, we also do have combination reliever controller.
Correct.
In this instance, do we have any products available in the public sector which can be used?
No, the products for rhinitis that are a combination of an inhaled corticosteroid and an antihistamine have really only just been launched in South Africa recently. They are not available in the public health sector. In the public health sector, we are using a combination of an intranasal corticosteroid with an oral antihistamine so that we can have the anti-inflammatory effect in the nose and the reliever therapy orally, but it's not available in a single combination therapy. In the state sector for asthma, we do have combination therapy of inhaled corticosteroids with a long-acting beta-2 agonist that has a very rapid onset of action. So we can even use combination therapy with your reliever combination therapy in the state sector, which is a great advance in recent times.
Superb. Prof, this regulatory T cells, it's a field I'm also leading, as you present today. Is there a way to enhance their function? Because it seems like even if someone is sensitized, if you have a very well-functioning regulatory system, you should be able to do well.
So Lesego, that's the whole point of doing allergen immunotherapy. In terms of, is there a natural way of doing allergen immunotherapy? There are some people who they say, well, they're allergic to cats but they're not allergic to their own cats. They're allergic to everybody else's cats. And that's probably because they've done an allergen immunotherapy with their own cat on themselves, and they've become desensitized to their cat. We don't really recommend that if you're allergic to an animal, you go out and buy 10 animals, because that could be problematic. And then the other thing that is generating a little bit of interest at the moment is the use of probiotics and prebiotics, but there's no evidence that we can use pro and prebiotics for allergic rhinitis at the moment, although there's increasing evidence that you can use probiotics and prebiotics for the treatment of atopic dermatitis. And that's something that in the next, I predict, 5 years, we will find lots of different topical ointments that have either got probiotics in them or killed biotics that have now got those bacterial products in order to help you induce regulatory immunity.
Superb. Though, Prof, you have addressed the issue of oral steroids, I see a number of additional comments around it. I see it's a stepwise approach, like the asthma protocol. With regards to oral steroids, do we always have to wait until the 4th step, or is there a place to consider oral steroids?
There's no step for oral steroids until everything else had been done. Again, the risk-benefit ratio is far too high. And if you're going to use oral steroids, really try use them for 3 to 5 days and then stop, because they will cause problems. And you can get away with using topical therapy. There's a couple of interesting questions about angioedema. That's Masood, who was unable to speak because of the mic. Angioedema is not really associated with allergic rhinitis, no. Urticaria and angioedema often go together in terms of systemic type of immune reactions, but not with a localized allergic reaction. And Abel Modiba asked, is sinusitis having the same presentation as allergic rhinitis? The answer is no. Sinusitis causes pressure, pain, purulent discharge, and that needs both an antibiotic as well as a decongestant and a corticosteroid in order to open up those tubes and let all of that stuff drain out. And it will be a very different presentation. But just remember that when your patient comes to you, particularly in my part of the world, they often say, "Doctor, I've got sinus." And that sinus often means they've got allergic rhinitis. It doesn't mean that they have sinusitis. So when a patient comes to you with a specific presenting sign, you should always ask a little bit more clearly to make sure that you're 100% sure about what it is that they're actually saying.
Yes. Let's see if Leon can really make our day. Leon, are you able to hear us?
Oh.
Yes, you may.
Yes, we are. Can you hear me?
Yes, we can, Leon.
Thank you, Prof. Just as something a bit off track here. Patient with severe dairy allergy and been proven, on exposure time and time again. Same patient, obviously, with sort of seems to be sulfur dioxide sensitive, preservatives and stuff. None of the allergy markers ever came back positive. Quite strange. I don't really know how to find out what is the full complexity of this.
So Leon, I'm going to send you an invoice for free medical advice straight after this meeting.
It's very kind of you, Prof.
First of all, in some forms of allergy where IgE is not involved, your allergy tests are going to be negative. So there's no point in looking for IgE if IgE is not the mechanism of the reaction. The second thing is, although everybody seems to believe that if you drink dairy allergy, you will get lots of mucus and you will get snotty and you will have thick mucus in your chest. The people who allegedly have that condition, when they are observed under controlled trials where they don't know whether they're ingesting that food or not, they find that there's no effect whatsoever. And often when they believe they're ingesting that food, even when they're not, they have these symptoms. These symptoms are very, very subjective. So it's we do not believe that there is any link, except in the form of a patient who's also having other signs in the setting of anaphylaxis with an urticarial rash and vomiting and diarrhea. Yes, they can have chest symptoms at the same time, but we do not believe that there is a link between ingestion of dairy and chronic sinusitis, runny noses, or chest issues. Your second issue in terms of sulfites, the reason you will have negative tests for sulfites is because it's not an IgE-mediated allergy, so you won't find that in any blood test. And just as a word of warning, please stay away from some of the tests that are unvalidated and in fact are many of them fake, charlatan tests. These include the LCAT test and other forms of testing for IgG antibodies. Because if you have IgG antibodies, they actually show that you are tolerant to an allergen, like I explained about the class switching, not allergic to the allergen. It has to be an IgE test. So all of those very expensive 4,000, 5,000 Rand for a test kind of tests that are based on IgG testing are essentially somebody ripping you off and giving you bad advice. And they are the ambit of the homeopaths and the alternative medical practitioners. None of them are validated and they should not be used by doctors.
Thank you, Prof. You can send me your bank account number. Appreciate it.
Thank you, Leon, for that. Prof, yes, I think there's just I saw a question around lactose intolerance. I can't see where it was. I thought that.
Yeah, so again, I don't want to talk about milk much because people think that there's a link between milk and the nose and the sinuses when there isn't. And besides, lactose is not an allergy, it's an intolerance, and it's caused by an enzyme deficiency, not an immune-mediated reaction. So it's really a completely different type of condition. It causes fartiness and bloating of the belly and being burpy a lot, but it doesn't cause urticaria. You can't pick it up with IgE testing, and it doesn't have an impact on the airways or the nose.
Superb. Thanks, Prof. Let's see if we can take the last question of the day. Manong, are you able to unmute? Manong? Okay, I think Manong, giving you last chance. All right, I think it's a mistaken hand. Okay, Prof, just to say thank you for today's webinar. This was quite an empowering session. I have learned a lot about type 1, type 2, IFN, gamma, ILL4. Prof, I just got it today. You can be assured that you have transformed at least one health worker.
Good. Well, I'm hoping that the rest of you had some benefit from the pathophysiology, but more importantly from the clinical things, and that you join us on that website for the Allergy Foundation, where you can get all sorts of useful information, not only about rhinitis, but about asthma, eczema, urticaria, angioedema, anaphylaxis, drug allergy, blah, 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 all of these things. So please look at our website, allergyfoundation.co.za.